Well, hello everyone. Thank you very much for the opportunity to speak to you tonight. What I want to do is provide a brief overview of the three most common gynecologic malignancies, ovarian, endometrial, and cervical cancer, and to discuss our treatment approach from a surgical standpoint to these diseases. Yes, I'd be happy to. Before we actually delve into each of the cancers, I think it's always important to look at the most recent statistics of cancers that affect American women. And so the most recent data that we have show that the most common cancer amongst American women remains breast cancer, with a lifetime probability of developing breast cancer of approximately 1 in 8. But what I want to point your attention to is the fact that of the 10 most common cancers that affect American women, 3 of them are gynecologic cancers. The most common gynecologic cancer is cancer of the uterus, which has a lifetime probability of 1 in 38, followed by cancer of the ovary, 1 in 72, and then followed by cancer of the cervix, which is 1 in 147. When you look at, however, the leading causes of cancer deaths in the United States, and this is data from last year, you can see that although endometrial cancer is the most common gynecologic malignancy, the most lethal gynecologic malignancy is ovarian cancer. And ovarian cancer is also the 5th most common cause for cancer deaths amongst women. Looking at the whole numbers, again in the United States last year, between 80 to 90,000 American women were diagnosed with a gynecologic malignancy, most commonly endometrial cancer, followed by ovarian and cervical cancer, and then a little bit more rarely, cancers that can affect the vagina and vulva. And then again, looking at the estimated deaths, ovarian cancer is the most lethal, claiming approximately 14,000 American lives every year. So ovarian cancer, as I mentioned, has a lifetime risk of 1 in 71 or 1 in 72 in the general population. And by and large, ovarian cancer is a disease that affects the elderly. The caveat to this is if you have a genetic predisposition for ovarian cancer, meaning you have a gene mutation in the BRCA gene, which I believe will be discussed later on this evening. Where does ovarian cancer come from, and what are the risk factors? Well, the dogma of ovarian carcinogenesis has always been naturally that ovarian cancer must come from the ovary. And in the 1970s, Dr. Fathala theorized this incessant ovulation theory, where he believed when a woman underwent their normal ovulatory cycle every month, the surface of the ovary would rupture and repair so that the egg could be released for fertilization. And he felt that when the cells had ruptured and repaired, that some part during this process introduced a mutation that ultimately led the cells to grow uncontrolled and ultimately led to the development of a tumor. We actually have studies that have shown that women who have fewer ovulatory cycles in their lifetime actually are protected against ovarian cancer. So many of you have probably heard the fact that women who have had multiple pregnancies in their lifetime seem to have a reduced risk of developing ovarian cancer, because when you're pregnant for those 9 months, you're not undergoing ovulation. Women who have taken oral contraceptive pills over a course of their lifetime also seem to be protected against ovarian cancer, because when you're taking oral contraceptive pills, you're inhibiting ovulation. And so this is what's been the thought of where ovarian cancer came from. But what I want to tell you now is that there has been emerging evidence over the last 10 years, and really concentrated over the last 5 years, that in fact ovarian cancer may not start from the ovary, but perhaps may start from the fallopian tube. And we've seen now where patients with ovarian cancer and women who are at the highest risk for developing ovarian cancer, those with the BRCA gene mutation, actually have precancerous lesions within the fallopian tube. And so there is now a campaign initiative in this country and in several other countries to remove the fallopian tubes in women who are undergoing hysterectomy for non-cancerous reasons, with the hope that by removing the fallopian tubes, that the risk of developing ovarian cancer in the future will either be reduced or hopefully eliminated. Again, this has really been emerging evidence, and time will tell whether or not by removing the fallopian tubes we do see a reduced risk of developing ovarian cancer in this country. In terms of screening, ovarian cancer unfortunately is a cancer that is difficult to detect at an early stage. We have tried many different modalities, including imaging. Probably the best imaging modality to look at the reproductive organs is ultrasound. And we have found that doing ultrasounds in asymptomatic women annually does not allow us to detect ovarian cancer at an early stage. There are tumor markers, and the most specific tumor marker for ovarian cancer is CA125. CA125 was discovered in the early 1980s by Dr. Robert Bast, and since the early 1980s, this has been the best marker that we have identified to measure treatment response in patients with ovarian cancer. What that means is that patients who have ovarian cancer that undergo surgery and chemotherapy, we can use this CA125 marker to determine if they've had a good response and also to determine if the cancer is coming back. Unfortunately, we have looked at using CA125 to screen patients who have pelvic masses to see whether or not this mass could be ovarian cancer, and unfortunately these screening results have not been good. And the reason why is because other medical conditions increase CA125 as well. For example, pregnancy, fibroids, appendicitis, basically any itis of the abdomen or pelvis, any inflammatory or infection can cause an elevation in CA125. So because it is not a very specific marker and because other things can cause it to be elevated, it has not been proven to be a good screening test. There is still ongoing research on combining CA125 with other blood markers to see if these markers in conjunction with each other could potentially be used as a screening tool, but these have not been fully elucidated yet. And then finally, I want to make the point about symptoms of ovarian cancer. As many of you probably know, for many, many years, ovarian cancer was called the silent killer. This is a misnomer. Okay, ovarian cancer is not a silent killer. But many people thought it was a silent killer because they felt they had no symptoms until they were already with stage 3 or stage 4 disease. But over the last 10 years, and a lot of this work has come from the University of Washington, for the last 10 years we have identified symptoms for ovarian cancer. Now they're not very specific, but they are symptoms that a lot of ovarian cancer patients share. For example, you can see here on the picture on the right, bloating, feeling full quickly while eating, which is what we otherwise call early satiety, pelvic or abdominal pain, urinary symptoms, abnormal bleeding or back pain. And so the University of Washington developed an ovarian cancer screening symptom tool for clinicians to use to determine whether or not patients with these nonspecific symptoms who had this over a period of time, whether perhaps they could be developing ovarian cancer. And over the last 10 years, our field has really tried to make the effort not only to educate our patients about these symptoms, but more importantly, to educate our doctors, to educate our gynecologists, to educate our primary care physicians who are really seeing these women when they come in with abdominal bloating. And in the absence of an obvious medical reason for some of these symptoms, the suspicion for an ovarian cancer must be raised. And so I want to make that very clear that this is not a silent killer, that there are symptoms, but it's our job now to educate our patients and our clinicians to have a little bit more of a higher awareness about these symptoms. The mainstay of treatment for ovarian cancer is surgery. And I've put some very basic terms on the left here. A total hysterectomy means removal of the uterus and the cervix. A unilateral salpingo-oophorectomy means removal of one ovary and one fallopian tube. And typically we reserve this type of surgery really for a small subset of patients who have a certain type of ovarian cancer called a germ cell tumor or a borderline tumor, which is not a fully invasive tumor. And these women tend to be young and they tend to be fertility desiring. But by and large, the vast majority of ovarian cancer patients undergo a bilateral salpingo-oophorectomy, which means removal of both of the ovaries and the fallopian tubes. The omentum is a fatty tissue. It can be thought of almost like a fatty apron that covers our intestine. And unfortunately, it is a wonderful place for cancer cells to stick to and grow. And so we remove the omentum routinely for this reason. And then finally, the lymph nodes that line the vessels in our pelvis and abdomen are potential places where ovarian cancer cells like to hide. And so we routinely remove these lymph nodes in order to see whether or not there are ovarian cancer cells. And if there are, then for therapeutic reasons to remove the cancer cells. I put this picture here on the right because I want to show you that ovarian cancer has no bounds. You can see here all those yellow spots are tumor, and ovarian cancer unfortunately travels to many different places, including the lungs, the diaphragm, the liver, the stomach, the intestine, in addition to the reproductive organs. And so our treatment philosophy towards patients with ovarian cancer is to remove all visible tumor. And the reason why we go to great stakes to remove all the visible tumor is because we've looked at the data regarding patients who have undergone complete cytoreductive surgery. And so I don't want to belabor you with too many details, but I want to show you here. The line in blue are women who had ovarian cancer that had a complete cytoreductive surgery, which means all of the visible tumor that the surgeon could see was successfully removed. The line in the middle, the yellow line, are patients who had their cancer removed, but there was still tumor implants that were 1 centimeter or less. And then the last line, the gray line, are patients who had their surgery, but they had tumor implants that were left behind that were 1 centimeter or greater in size. And usually it's because the surgeon was unable to remove those tumor implants for whatever reason. But what I want to point your attention to, and don't worry about the numbers, is the patients, the blue line, the patients that underwent complete cytoreduction had substantially longer lives. They lived 2 to 3 years longer than women that did not undergo a complete cytoreduction. And this study has been proven time and time again. And for this reason, we take really great effort to do a completely thorough job. And sometimes these surgeries can be complex and they can be long, but we feel very strongly that removing all of the visible tumor to the best of our ability really gives the patient the best chance to live as long as possible. Moving on, endometrial cancer, as I mentioned, is the most common gynecologic malignancy with a lifetime risk of 1 in 38. Again, this is in the general population. There are women who have a higher risk of developing endometrial cancer if they have a gene mutation in the DNA mismatch repair gene. And these women are termed to have what's called Lynch syndrome. Lynch syndrome is a cancer diagnosis that increases a woman's risk of endometrial cancer, colon cancer, and less frequently ovarian cancer. But unlike ovarian cancer, where the majority of ovarian cancers are detected at a later stage, endometrial cancer, fortunately, is detected usually at a very early stage. And the reason why is because we have very good symptoms that present at an early stage of the cancer development. The thoughts behind how endometrial cancer develops currently is that there is a hormonal imbalance where there are higher levels of estrogen circulating in the patient. And we're finding that the reason why there are higher levels of estrogen in these patients is because a lot of our patients that are at the highest risk for endometrial cancer are also obese. We are seeing every year in this country, the endometrial cancer rates are rising. And the question is, why are endometrial cancer cases rising every year? And if you look concomitantly with the obesity rates in this country, they look like they're traveling in parallel. And the idea is that the fatty tissue that our body has a enzyme that can convert our androgens into estrogen. And so women with a little bit more fatty tissue, for that reason, tend to have higher levels of estrogen, which can then increase their risk for developing an endometrial cancer. The presenting symptoms, most commonly in patients that have undergone menopause, are women that have postmenopausal bleeding. And often patients come to their doctor and say, my period stopped 5 years ago and all of a sudden I've started to bleed again, or I've had spotting. And so this raises our suspicion for a possible malignancy, and we biopsy these patients right away, because this situation of postmenopausal bleeding is a cancer to us until proven otherwise. For women who are still having their periods, we often see our patients say, I have my periods every 28 days and all of a sudden I'm starting to bleed in between my periods. And unless there's an obvious medical reason for them to have bleeding in between their periods, we often will test them as well to see whether or not they potentially could be developing an endometrial cancer. As I mentioned before, because endometrial cancer is typically identified in an early stage, the mainstay of treatment is surgery, which is a hysterectomy.
You said that it's identified usually early, is that what you said?
Yes, it's usually identified at stage 1 or stage 2, which means the cancer has not spread beyond the inside of the uterine lining, which you can see here in that photo. And if that is the case, then we remove the uterus. Now, sometimes the cancer has spread beyond the uterus, at which time patients will need a combination of either chemotherapy or radiation or hormonal therapy. I put this data here again, the most recent data we have on the bottom right, to show you that, again, the vast majority of patients of endometrial cancer are diagnosed at an early stage. And more importantly, when you look at the local for uterine cancer, the 5-year survival rate is 96%. It's extraordinarily high, which we feel very good about. It means that when we catch these cancers early and we do the surgery in a timely manner, our patients live for a long time. And in fact, I routinely tell my patients that when they have a stage 1 cancer and the surgery's been done and they don't require any other adjuvant treatment, meaning they don't need any chemotherapy or radiation afterwards, I routinely tell them that you will live and you will not die from your cancer. You will die from another condition. The surgery for endometrial cancer, as I mentioned, is a total hysterectomy with removal of the fallopian tubes and ovaries, and also a lymph node dissection. And I think this picture shows very clearly why we remove the lymph nodes. You can see right next to the uterus are all of these green little lymph nodes where cancer cells use as ways to travel throughout the body. And you can see in this picture on the left, our lymph node chains extend virtually throughout our entire body. And so removing the lymph nodes that are at the origin, that are the most closest or in the closest proximity to the uterus, are important to remove, and those are the pelvic lymph nodes. The pelvic lymph nodes then travel up to the abdomen where they line the great vessels. We call that the aortic lymph nodes. And so we routinely remove these pelvic and aortic lymph nodes, again, for 2 reasons. 1, to see if cancer is there. This allows us to stage our patients. And 2, if the cancer is there, to remove those cancer cells and prevent those cancer cells, hopefully, from traveling beyond these lymph nodes. Traditionally, when we did these surgeries were traditionally done through an open incision, and that's the picture here on the left. Patients typically had these surgeries done through a similar incision to when a woman has a C-section. Sometimes women would also need to have these incisions done vertically. But now, over the last 20 years and all of the advances we've made with minimally invasive surgery, we can do the same surgery with the same outcomes through smaller incisions. And you can see a picture of the woman on the right with 5 little incisions that are no bigger than the width of my thumb. On the right here, you can see what we do these surgeries with. We call this the Da Vinci robot. And the surgeon is sitting at the console manning 2 joysticks. The patient is away from the surgeon, and the robotic arms and camera are inserted through these small incisions into the patient, and you have another doctor or assistant next to the patient to make sure that the arms are working and functioning properly and that the patient is doing well. But the most important part behind doing these surgeries is that, and I'm showing you again data down here, and I'm just going to basically emphasize the main point, which is that the same outcome, doing these same surgeries through the small incisions, were achieved, but the recovery time, the complications were less, and the estimated blood loss was less. So the benefits of doing this surgery through smaller incisions and with the precision of using a robot has basically really improved our ability to provide better care for patients with endometrial cancer. For example, here in this chart, you're seeing length of hospital stay. After a robotic surgery, the average length of hospital stay was 1 day, compared to patients who had an incision who routinely would stay in the hospital for 4 to 5 days. More importantly, patients who had to recover from an open incision typically would not feel well for the next 6 to 8 weeks. And usually after 2 months after a big incision is when patients would start to say that they felt similar to how they felt before the surgery, compared to when we do the surgery with a robot, where patients routinely tell us after 2 weeks that they are ready to go back to work, that they feel well, that they want to exercise again. And so this type of surgery, this type of technique has really improved the quality of life of our patients with endometrial cancer. And then finally, cervical cancer. The lifetime risk is 1 in 147 in the general population, and the incidence continues to decline in the United States and other developed countries, primarily because we have a very good screening test, which everyone knows is the Pap smear. The Pap smear truly is the gold standard for screening amongst all screening tests that we have for any type of cancer. The other reason why the incidence is declining is because of the advent of the HPV vaccine, which I will talk to you briefly about. How does cervical cancer form? Well, cervical cancer is derived from the human papillomavirus, HPV. HPV is a sexually transmitted pathogen. There are approximately 100 strains that we have identified of the HPV, but of those 100 strains, we have identified 2, HPV 16 and HPV 18, that we know account for the vast majority of cervical cancers. Approximately 75 to 80% are the result of these 2 strains. I'm showing you the picture on the bottom right because I want to show you that unlike the other cancers, cervical cancer does not happen overnight. The HPV virus affects normal cells of the cervix, and there is a stepwise progression into a fulminant cervical cancer where you see the normal cells change into what we call precancer cells. Sometimes your doctor will say that you have a dysplastic cell, which is basically the same thing. And then again, over time, those precancer cells develop into a cervical cancer cell. And the reason why this is important, and the reason why we emphasize in this country for Pap smear screening, is because we can detect these precancer cells, and we can do something about these precancer cells to prevent these precancer cells from developing into a cancer. And usually that involves excising a portion of the cervix with those precancer cells. So often when patients do develop cervical cancer, it is often in a setting where the woman tells their doctor, I have not had a Pap smear in over 10 years. The treatment for cervical cancer depends on the stage of the cervical cancer. If the cervical cancer is detected early, we typically offer surgery, which I'll talk about briefly. If the cervical cancer is detected late and the stage is a stage 2, 3, or 4, then we typically do not offer surgery, and instead we offer chemotherapy and radiation in conjunction. There are many different types of surgery for cervical cancer, and again, it really is dependent on several factors. One, the stage of your cancer is really the most important. And for the earliest stage of cervical cancer, stage 1A1, it is reasonable if a woman is young and strongly desires to preserve her ability to carry children, that we can do a cone biopsy where we remove a wedge of cervical tissue that contains the cancer. Likewise, and again, this really relates to younger women who strongly desire the ability to carry children, we can also do a radical surgery called a radical trachelectomy. And these are women that still have an early cancer, but a little bit beyond the earliest stage, stage 1A1. And these women, we can offer them removal of the cervix and the upper part of the vagina. We can preserve the blood flow to the uterus and then reattach the uterus to the vagina. And we typically then use a stitch to close the opening of the vagina into the uterus, because now there's no cervix. You remember, if you bear children, the cervix has to open. So we, since there's no cervix, we actually put a stitch there to keep the uterus closed, so that as a woman does go into pregnancy and the child develops, then when they're ready to have their child, there won't be issues with preterm labor or preterm delivery. However, for the vast majority of our patients, again with early stage disease, we offer a radical hysterectomy. And I'm showing you a picture here on the bottom left where you can see the cervix, which is removed with the uterus, the upper portion of the vagina, and then there's tissue to the sides of the cervix. There are literally tissues that emanate directly from the side of the cervix called the parametria. And the reason why we remove this tissue is because with cervical cancer, it is vitally important to remove not only the tumor, but to obtain a negative margin. That means you not only want to take the tumor out, you also want to take some tissue outside of the tumor that's not affected with cancer cells. Because if, for example, you remove the tumor, but you leave cancer cells remaining, or you leave a tumor nodule in place, the patient will almost certainly recur in that area. I want to show you the picture on the left, which shows in blue a tumor that has started from the cervix, but this time you can see it has spread to the lateral sidewall. And you can see here that the tumor is basically involving the lateral sidewall, touching the pelvic bone, and also involving this tube-like structure, which we call the ureter. That's the urinary tube that connects your kidney to your bladder. A woman with this type of cancer is stage 3B. And the reason why I wanted to show you this picture is because I want you to see our philosophy, why we remove the parametrial tissue and the cervix and the upper vagina with the uterus. If the tumor is isolated to the cervix, then we remove this tissue because we want to get tissue that doesn't have cancer cells. But here you've got cancer that's going all the way to the pelvic sidewall. So in order to remove all of this tissue and to get tissue that does not have cancer, we would literally have to cut into the pelvic bone. And that is not a feasible surgery, and that would not provide any benefit to the patient. So these patients with advanced cervical cancer, when people ask, why can't you do surgery? Why can't you remove my uterus and cervix? This is the very reason why we don't offer surgeries, because in order to remove everything, we would have to be able to get negative margins. We'd have to get tissue that's not involved with cancer. And so these patients are treated instead with radiation and chemotherapy in order to shrink and dissolve this tumor. And then finally, in terms of screening, as I mentioned to you before, Pap smear screening is the gold standard for detection of precancerous cervical cancer cells. Pap smear screening, our guidelines change every several years. A lot of it has to do with our detection rates of precancerous lesions and cervical cancer, and also a lot of it has to do in our country with cost-benefit analysis and looking at the cost-benefit ratio of detecting a cervical cancer to find one amongst many women that undergo what people feel are unnecessary Pap smears. Pap smear screening currently is recommended to start at the age of 21. The frequency and stopping guidelines vary. What you're probably used to hearing is that Pap smear screening should be done annually, and for many years that's exactly what we were doing. But the most recent guidelines actually have recommended that in women who have a history of normal Pap smears, that it is completely reasonable to space their Pap smear screening by every 3 years. And to me, almost incredulously, in some women, they've even recommended extending the Pap smear screening by every 5 years. And those are women that really have no history of abnormal Pap smears, who are between the ages of 30 and 65. And when they undergo their Pap smear, they also have HPV testing, because as I mentioned to you before, HPV is really the culprit that leads to a cervical malignancy.
Is that just a blood test?
No, it can actually be taken from the actual cervical tissue specimen. And then finally, the HPV vaccine is approved now to give to our children and adolescents and young women and men, for girls ages 9 to 26 and boys ages 9 to 21. I put this picture here on the bottom left because I think the CDC has done a nice job really emphasizing the key point, which is HPV vaccine is cancer prevention. And the reason why I think this is really important to know is because there are some groups in our country that feel that giving this vaccine to our children and adolescents promotes sexual promiscuity. They feel that this vaccine is an STD vaccine. And I really want to emphasize to you that this is not an STD vaccine. This is a cancer vaccine. And I do feel very strongly for this reason that our children and adolescents and young people should be vaccinated. So with